Centro for giving me this opportunity, and also thank your Executive Director, Mrs. Gomez, for giving me this opportunity to be with you this morning, to talk to you about a subject that is very dear to my heart. I have been given exactly 1 hour. The clock is ticking. It's right in the back, so they'll slap me on the hand if I don't follow the exact timing I've been allotted. So please bear with me. I'll try to convince you that this patient-centered care approach is more than a fashion. Healthcare system to steer its way through these trying and difficult times. My challenge, and I found out that that challenge only last week. I didn't know. I was the speaker given the task to kick off this seminar, this forum. So my challenge is to interest you in this subject. You are numerous in this room. I'm sure you're very curious to find out what this strange guy from a strange country has to say about patient-centered care. I will try to convince you that there is something more to it than just theory. My lecture is in part based on theory. Some of my slides are Canadian Council of Health Services accreditation vintage. Some are my own hospital's vintage. And hopefully my experience, although not necessarily a model that can be directly exported to your country, there are principles in this experience that I will share with you that may be helpful to your situation. You will have my slides presented to you in Spanish. You have them in your documents. I was told that they are on a CD. So you can look at them when you go back home. Hopefully you all have access to a portable or a PC computer. Otherwise, the CD won't be much help. But if that's the case, you can always call the Centro, and I'm sure they will be very glad to forward you copies of my presentation in Spanish. First slide, please. This first slide is only to emphasize that the changes that are currently affecting the development of healthcare in your country are changes that are affecting healthcare throughout the world. The list of changes, trends that affect healthcare is just a summary that is shown on this slide. But I'm sure this summary is, if you look at your own experience, represents pretty much what you are experiencing currently in your own country. At least from my country's perspective, these are some of the elements who have influenced the changes that have been brought forward in our healthcare system and in my own hospital. One of the most important, and I will spend some time on this one, greater consumer involvement. Our legislators have even put in our legislation provisions to include patients, their representative on boards at all levels of the system. It's expected that patients be involved not only in the care process, but also in the decision-making process of the healthcare system. So this is a very dramatic change that has been introduced some years ago in our healthcare system, and I'm sure similar changes are occurring elsewhere in the world. Patient-centered care is also another trend, and I'll try later on to show you that it's more than just a fashion, as I said in my introductory remarks. Standardized care based on evidence. I think that during your conference you will hear other speakers address this issue, so I won't emphasize this point. But let's just mention for the sake of this presentation that standardization is also another very important element that is influencing the development of healthcare. And you will see also through some of my examples I will show you how these have affected even the organization of a hospital. Improved information system. You have just to think of the horror that the year 2000 anticipation brought on every countries in the world. We depend more and more on information system and automated information systems. So this is another important trend. Education to support change. With consumerism also comes the impact of better education, better knowledge. I would also venture that access to internet is also another major development. It's not on this slide, but from my experience, and I'm sure there are doctors in this room who've had this experience with their own clients, patients that come in their cabinet and are discussing clinical matters with them because they have access to the same literature, clinical information that you have access to through internet. System-wide standard setting, national leadership coordination, increased accountability, all other elements that influence the development of the healthcare system. And added to that, major problems in your country. They are not the same types of problems, but in my country, just to put you in perspective, some of the changes that have been brought in my organization were in part motivated by the effect of dramatic budget reductions in the hospital care, shift of the focus of healthcare from acute to long-term community care, outpatient services, ambulatory care. So these had a very dramatic impact on the organization of acute care and acute care hospitals. Coupled to that, dramatic reductions in staff, major reductions in personnel. Just to give you an example, over a period of 3 years, 25% of our staff were retired from the hospital. At least 600 or 700 employees had to change jobs in a matter of a year and a half. So these were major dramatic changes for the staff who were being oriented in new jobs, had to cope with new colleagues, new types of services to be provided, new expectations of performance in their job. Why has the focus on patient or client increased? Well, apart from what the international trends have brought about, there is a list on this slide of a few of the elements that have forced, at least in my country, hospitals, healthcare organizations to change their focus. By tradition, patients were more considered a means to achieving the final goal, which is to gain a salary, gain prestige or whatnot. I'm sure this is not the case in Colombia or in any of the South American countries, but at least in Canada, when you walk into a hospital, you have the distinct feeling, talking to the admitting clerk, that you were disturbing her routine. This had to change. I mentioned consumerism. Patient with better education, better knowledge, forced us to change our perspective, forced our personnel to see that patients are more than just a means to achieving a salary, a better standing in life. There are other examples of how consumerism is also affecting the healthcare system. Some of you may have traveled to France. Some of you have come to Canada. You are probably aware also of some of the lists that have been published in the United States. France has published over the past few years the list of the 100 worst hospitals to be admitted in. Canada has taken another position. Our journalists are a little milder with us. They published a list of the 100 best hospitals in the country. The United States lists doctors by their risk adjustment type of practice, for instance. So there is now a body of knowledge available to the public about how well they will be treated in hospitals, how well their professionals are going to take care of them. This is affecting dramatically the attitude of personnel, of staff, of healthcare organization. I won't go into detail with the other elements. Let's just mention legislation to give you an example how legislation is forcing change also on healthcare organization. In my province, in a huge transformation of the legislative body surrounding our healthcare system, the legislation introduced at least 50 article paragraphs dealing with patient rights, ranging from anywhere from confidentiality of information to complaints, how the complaints should be handled by the system, even establishing different specific positions to hear patients' complaints and ensure that patients' complaints are given due follow-up, if you like. Now coming to my experience, this slide shows you in a nutshell something like 8 to 10 years of work. This is the model that the Hôtel Dieu d'Arthabasca developed over those years, a model that was developed through trial and error. I will not brag about it. We had to work teeth and nail, the leadership team, the professional team, to develop this model. What it shows in a nutshell is how the patient-centered care fits into our model of organization and of providing care. It starts with our vision, our mission, and our values. And everything that is derived from that has to tie in with our mission and vision, which give us the purpose and meaning of our organization. The client-centered approach is our guiding light, if you like. In accounting terminology, we call it the asset test. It's what we use as the principle on which we base all our decisions. And I'll talk to you in more detail about that. Teamwork and shared vision are derived from the patient-centered approach. And I'll discuss that in more detail in another slide. And through teamwork, we realized that we had to bring about organizational change as well. It was not enough over time to bring around the table all those actors interacting in the care process for one stream of patients. We had also to create to put all the elements that were favoring the teamwork interaction, and in doing so we had to create a structure that favored not only the presence but also the sharing of the experience and knowledge of all those professionals involved in the patient care. And this is where the path that leads us to continuous quality improvement. Just for the sake of this presentation, I thought it would be interesting to see how we define quality improvement in our organization, and this is taken out of the Canadian Council of Health Services Executives documentation. This is how we Canadians define continuous quality improvement. So it's a philosophy, and as I said, patient-centered care in my organization is our guiding light. And the guiding light, to a certain extent, is equal to a philosophy that seeks to meet not only clients' needs, those that you as professionals think through your professional judgment, think that the patient requires, but also to exceed their expectations. That word is very important to me. It's, I think it hasn't been put in bold letters, but if I had to redo that slide, it would be in bold and underlined. Our patients have expectations. When they come through our doors, they judge us the minute they step into the hospital, and they start evaluating us. And it's important to know, to understand on what elements of care, of the environment in which we provide care, they base their judgment of the quality of care. If we don't pay attention to these expectations, our future is in jeopardy. My hospital has existed for over 115 years now. I could argue maybe it's going to last another 100 years. But you all know from experience, there are big companies who thought their future was insured. They didn't pay attention to their clients' expectations. They were too enamored with their product, not enough with the clients of the product. And they disappeared. Sure, patients will always need health care, but the way it's provided can change dramatically. And we have to adapt to new scientific knowledge, but also new expectations from our clients. So expectations is a very important element of quality improvement. The other elements, minimum effort, rework, and waste, and I'll give you examples, at least one, of how meeting or improving the expectations of patients and their needs can also be a cost reduction strategy. By using structured process that selectively identifies and improves all aspects of care and services on an ongoing basis. In my organization, the continuous quality program is based on several main principles. These are listed here. The first one, and it's not a hazard, that I talk about patients first. And I have another story for you. It used to be that when we wrote our annual report, the first page or the first few pages dealt with financial reporting. Our board meetings agenda dealt with financial matters first and foremost. Somehow we were paying more attention to financial matters than to the real business of a hospital, of an acute care facility, the provision of care. Just to change that routine of dealing with financial matters was something that was not ingrained, that took time to convince people that it was more important to deal with the real matters, how patients perceive our services. So the continuous quality program in our organization is a means to improve the accountability of our organization to patients. And not only patients, but also their representatives who are, as I mentioned, part of the care team. It's expected that in planning and delivering care, patients are involved. And sometimes their families, if that's their wish, are involved. But further than that, they are also involved in the decision-making process. They are involved at the board level. They sit at the board level. They are also involved in a specific committee of the board that deals with patients' complaints, for instance. There is a mechanism to forward complaints of patients directly to that patient's committee, and the committee can handle complaints, meet with representatives of the medical staff, the professional staff who deliver the care, essentially ask for explanations from the professionals. That is changing a lot the relationship between the professionals who deliver the care and the patients who receive the care. It means that professionals have to pay attention to the patient's expectations and that they have to be accountable for the way they establish their relationship with their patients and their representatives. Accountability to patients also was an element in the development of our concept of service, and I'll go into more detail about what we mean by the concept of service. If I was to give an example, however, I could use McDonald's, who has a concept of service to organize the service, the delivery of hamburgers throughout the world. You know that when you walk into a McDonald's, whether in Colombia or in Montreal, you will be offered the same kind of service, offered with the same taste, in the same kind of environment. Let's say that our concept of service tries to use this experience, but in the context of a hospital. And accountability to patient was also an element to motivate our patient-centered structure, supported by multidisciplinary committees. Why I'm putting this there is that I remember 10 years ago when I stepped into my hospital, I could look at the organizational chart, and it took several university degrees to understand the complex relationships between the various departments and professionals in that organization. It needed my expertise to be able to deal with that complexity. Now let's put yourself in the shoes of a patient who walks into the door of the hospital and wants to understand what is happening with him and wants to talk to the people who take care of him. If they look at the organizational chart and you have to give them several years of university training for them to find their way in that maze, that defeats the purpose of the provision of care. So that was also an important motivator in trying to picture organization, draw an organizational chart that had meaning to the patients, that they didn't need to have several degrees, university degrees, to find their way through. Last but not least, it used to be that we were accountable to our stakeholders. Those were our Minister of Health. He would slap us on the hand if we were running into a deficit. It's still an important matter. I don't want to berate it or make it sound as if it's not important. But our stakeholders group has also enlarged with the patient-centered care approach. We no longer see our stakeholders just as those people in the Ministry of Health, but our community is also considered as an important stakeholder. Our partners, other healthcare organizations who act in the continuum of care, in the provision of care of our patients. To our population, how are we accountable? I mentioned our concept of service. Well, our concept of service was the tool by which we organized and trained our people, our personnel, as to what is expected of us when our patients come to our organization. But we mirrored that by a pledge of service, on which we pledge to our population and our patient, and this is advertised broadly in our community, on what basis we take accountability, what what can our patients, the population we serve, can expect when they come to our hospital. We tell them, and then later on we ask them, we tell them what our performance should be in terms of patient care expectations, and then we ask them to rate us once services have been rendered. In a nutshell, this is our continuous quality improvement. This is to portray to our personnel, and I hope it will, after this presentation, make sense to you how we try to make sense of the continuous quality improvement program based on the patient-centered care approach. So again, I mentioned that the mission, the vision, the values are first and foremost. They are the elements on which we base all the developments of our continuous quality improvement processes. Our concept of service was then used to develop our tools, how are we going to evaluate our processes? To put this in an image, I'd like to use the example of a cardiologist who tries to diagnose or establish the health status of the heart. He can evaluate the conductibility of the heart through ECGs. He can evaluate the perfusion of the heart through hemodynamic analyses. Radionuclide tracers can be used to trace the health status of the heart muscle. There are different tools that are used to evaluate different aspects of the same organ. If you put this in the context of an institution, for the sake of this presentation, let's think of a hospital as the heart. What we devised are different tools to evaluate how the hospital, the heart, is working. Is it working appropriately? And we found through trial and error that there are 4 basic dimensions of the heart of the organization that have to be monitored. The relational stream, the professional stream, the occupational stream, and the organizational stream. And it's through continuous monitoring of all of these streams that we are able to ensure that our patients are satisfied, that our personnel is also motivated and satisfied, and that our stakeholders are happy with our performance. Now I've mentioned the concept of service. What is it? What you see before you is a summary of what it looks like. This is the wording of our concept of service that we use in training our personnel. We have trained all our staff, the doctors, volunteers, everybody has been trained through a training program that was based on the concept of service. Before I go into more detail as to the content of the concept of service, let me just say that it was developed through a very lengthy process, a literature review, review of other facilities, organizations, survey material who've identified patients' expectations, and we also did the same work through focus group interviews with a number of patients, several tens of patients that we interviewed in focus group to find out what are the elements of care they expect and they judge our performance by. And it's through that lengthy process that we found a common trend of expectations in our patients. We use that to challenge our staff, to ask them, because when we started to talk about patient expectations, our staff would counter, hey, they'll want flowers on their bed table in the morning, we can provide that. They didn't know what patients expected. So we had to tell them, look, they don't expect miracles. Those things that they expect, do you think that they are things that you can deliver? Before we finalized the concept of service, we asked a majority of our staff, are these expectations that you think you can meet? And if not, why? The reason we asked was if they had told us, if our staff had told us, these are unrealistic expectations, then we could have gone back to our population, our patients, and told them, look, you come to our hospital and you have expectations that are too high given the resources we have. The same way, when McDonald's advertises its concept of service, you don't accept candlelight dinners when you walk into a McDonald's. You know exactly what you expect, because McDonald's did its homework. It trained its population, its potential clients. So the concept of service was both a tool to train our staff, but also a tool to sensitize our population as to what they could expect from us. And what do they expect? They expect competent staff members. They won't be able to judge the clinical competence of the professionals delivering the care. But it's little things like the nurse that comes to the bedside with a new machine, looks at the machine with puzzled eyes and says, ooh, I'm not sure how this works. How confident do you think the patient is of the competence of that nurse? Who would volunteer to be under her care? Not very many of you, I'm sure. Follow through on all the steps of the client-centered approach. Information concerning community-based resources. They want to know, once they leave the hospital, what can they expect in terms of support services. An environment which meets the standards of cleanliness, accessibility, and safety. When they walk into the emergency room, what do you think the patient thinks if he sees blood on the walls, dirt all over, the windows are very dirty? So these were just a sample of some of the elements of our concept of service. An organization is a myriad of processes, and we define processes as a series of interrelated steps. When I first took over the hospital, as I told you, there were 65 different departments, all bickering for their share of the turf. The patient was subdivided in 65 different pieces. The patient-centered concept of service is a way of putting back the human and putting the staff in perspective. What is their place in the care process? Once you put the patient at the center of the care process, that changes it changes how you approach the patient, how you organize the care of the patient. It changes the structure of the organization. And I'll give you an example later on. I see the time is flying by, so I'll jump to the other slide. In your material, you'll have an example of a surgical care process, but I thought I had a more dramatic example. In Chile, I used it, and people were a little impressed with that example, so I will use it for this presentation. Critical care is a very big problem in our province. Some years ago, we evaluated for patients suffering from acute myocardial infarct, what was the mean time of administering thrombolytic agents. We found out that we were just a little bit better than the average Canadian facility, who took 90 minutes to minister care to those patients. As some or most of you are probably aware, 90 minutes is not a very good performance. International standards call for 30 minutes. So we started working on that process. And it's through reorganizing, rethinking the organization, taking advantage of some of the big challenges we were facing. I alluded to retirement of staff. So one of the first steps that put us into the re-engineering, if you like, of that process was the retirement of a technician, an electrocardiography technician. Instead of doing the obvious, replacing that person, we thought, why don't we, while saving money, improve the equipment? We'll see how this affects the speed at which we administer care. We replaced that lady with machines. We put ECG cards in ER and in ICU, and we trained the nursing staff to do the same thing as the technician were doing. What we were trying to do essentially is save time in administering care, but also in using, putting better use of the professional staff time. We knew that nurses spent many, many minutes trying to comfort patients while the technician was running around the hospital with the ECG card and wasting time before he would arrive, place the leads, and have the tracing ready for the doctor to interpret. The nurses were busy calming the patient, and the technician busy running around with the cart in the hospital. What we did was we saved time on both sides. The nurses were still busy talking to the patient, but their hands were also providing technical assistance in placing the leads and providing the tracing, the ECG tracing. In doing that, we saved 15 minutes. We shaved 15 minutes out of the 85 minutes